Let's kick off with Focus on Health Law. This is a presentation of Mr. Kenneth Haber, attorney at law. The moderator here is attorney Ramesh Khurana of the Khurana Law Firm. This week, these two attorneys will address some of the questions concerning healthcare and accountable care organizations under the Healthcare Reform Act of 2010. Let's join them.
This is Ramesh Khurana, attorney at law. Welcome to the Capital Forum. I am very pleased to introduce Mr. Kenneth Haber, who is the former Assistant United States Attorney and a practicing attorney in Maryland in Boyers. He is very close to my office and we love each other company, and I know his professional experience, and I can attest to it that whenever I have made some referrals to him for different physicians, he has always come forward to help them to the best of the physician needs. And Mr. Haber, welcome to our studios.
Thank you very much, Ramesh.
Ken, I'm going to ask you questions concerning healthcare and accountable care organizations under Healthcare Reform Act of 2010. So I think this is a very interesting topic.
Timely.
Timely, very timely. Now, how will this legislation affect the totality of the doctor-patient relationship once it is effectuated through the regulation? Is it a difficult question?
It's not a difficult question. It's going to be difficult implementing it in this country.
Okay,
it's
great.
going to be affected totally from top to bottom because
this is what I thought. That implementation is very difficult.
When you tell the nation that there's $500 billion that's waste, fraud, and abuse, in order to be able to take that $500 billion and apply it elsewhere from Medicare, that's going to totally affect the Medicare program, which is a major instrument of health care. And you take that money and you put it elsewhere in the healthcare field, that's going to affect that field. So they've got to try to plug in 30 million Americans who do not have health care. And they're doing this as we sit here and speak now. They got to plug these 30 million people into the healthcare system and cut out $500 billion from the healthcare system of Medicare and make that Medicare effective still, and use the same number of doctors, because we haven't just graduated now 1 million doctors to help people out. It's a major feat. It's not just one state implementing a healthcare system, a healthcare program like in Massachusetts with Care. They're undertaking a major restructuring of 1/6 of our economy, and it's going to have distortions, and it's going to have positive and negative effects throughout the system over a period of time until everything is sorted out, and it may never recover itself, or it could recover. We could be stuck with a system like in England, where to see a specialist you have to wait months, or it could make more efficient health care where you don't see a specialist when you don't need a specialist. I would think that what's going to happen, it's going to be more and more difficult to see a specialist over a period of time, because more and more people are going to be demanding time of that specialist.
It's very horrifying to hear that we are going to have the same kind of plight for the patients here in the United States, like we hear these kinds of horrible stories in the United Kingdom. I also know certain people now who needed certain medical care urgently. They couldn't find it, they couldn't get it, and they decided to go to India for medical treatments because they could afford to pay in India out of their pockets. So it's interesting to know.
I have a friend who was in England. Her husband was a British subject, and she needed medicine. And she had to wait months to see a specialist, and she couldn't afford to pay for the medicine, and there was medicine available for animals, but she couldn't get it. The same medicine was for anti-parasites. And I had to go on the internet and order the medicine for her and ship it to her location in England for Fido in order for her to save her life.
Great job, Ken. I'm going to ask you another question relating to the first one. Now, will the accountable care organizations be major instruments for change in the practice of medicine through the Reform Act?
Yes, accountable care organizations and Medicare Advantage organizations are going to be the major players. Medicare Advantage organizations are insurance companies that are taking on roles of providing services where they're getting paid money by Medicare, a pot of money to take care of defined patient base. Many of them are going to be looking more and more like HMOs. Many of them are already looking like HMOs. The accountable care organizations are going to be groups of doctors who are going to be competing with these Medicare Advantage organizations, and they're going to be grouped around hospitals. And they're going to have specialists that are going to be involved in their organization, and they're going to be putting emphasis on the primary physicians, the PCPs, primary care physicians. And under the migration of the change of healthcare, these primary care physicians are going to become more than gatekeepers. They're going to be taking on more and more responsibilities to do some of the minor care that are taken on by the specialists at this time. So they're going to be taking on more of these responsibilities, getting rewarded for it, and people will be sent on to the specialists when there's no alternative, and the specialists are going to probably see the patients less and less and be more slicing and dicing for the surgery with secondary level care providers seeing the patients from an intake and exit position. Example B, you have an orthopedic surgeon and he's in the hospital slicing and dicing. He's got nurse practitioners who's at his office seeing the patients and determining whether or not it's appropriate for the surgery, and if it is, then they might see the surgeon the day of, or maybe they're under by the time the surgeon sees them, and afterwards they see that nurse practitioner again. I see this as a thing of the future because there's going to be more people, 30 million more people going into the system, and there's going to be no greater number of physicians coming in mass, and maybe even many of them exiting because of the changes. So everything's up in the air. What's going to come out, I don't have a crystal ball, but I'm just speculating at this time.
Got it. Now that leads to another question. Are hospitals the only ones being affected by Reform Act?
No, the hospitals are not. Although the Reform Act is going more and more, as you know, with global fees and such like that, that affects the hospitals. Get the patient in, get the patient out. Which has some virtue in that previously when the hospital was on the cost reporting system, they keep the patient in there indefinitely without any justification. Now, if there's justification, they can, get extensions for the patient to be in. But everyone's going to be affected. To answer your question, everyone's going to be affected. The consumers, the physicians, the insurance companies, the hospitals, everyone.
Ken, you just told us the concept of global fees, because our audience comprises not only doctors and physicians, and we have some lay people like me as well. Could you please explain what is the concept of global fees?
Yes, a global fee currently at the hospital is where, based upon your diagnosis, the determination of how much the hospital is going to be paid. I would see that that's going to become more and more even to the doctor's office, depending upon the diagnosis, how much is the doctor going to be paid. It'll be a concept that grows out of what they call the value-based payment structure. And they want to reward good services, and they want to build some sort of system to reward good services, and they got to consider the diagnosis and determining how much the doctor is going to be paid. But more and more, they're going to say, okay, the patient's coming to the doctor's office, he needs this done and this done and this done, and instead of sending them specialists, have the doctor do it, the primary care physician at the same time, there's the office visit, so they'll put it all together and make a global visit fee. It's not there now, but it's going to be there.
So is there any, so you mean that there is only one global office visit, and for that global office visit there is just one global fee? This is what you are saying?
Well, what I'm saying is that there will be as many visits as necessary for that diagnosis, but there's going to be one payment for it.
Okay, but what's the global office visit?
The global office visit would be taking in all the patient's problems at the same time.
Oh, I see. Okay, that's interesting. Now, what is section 3007? Value-based payment modifier under the Medicare physician fee schedule.
That is that it's a modifier that affects the amount of payments that the physician's going to get based upon the diagnosis and the efficiency of the treatment. You may hear that nowadays that if a patient returns to the hospital because of the same problem, that it hasn't been taken care of, the hospital has certain economic negative effects. Well, this is going to become more and more studied and more and more adjusted for. They're in with electronic medical records, and the government is going to be able to see exactly what the doctors are doing and holding the doctors accountable for it.
So Ken, we are running out of time, so we have to close this segment. And with this, I appreciate coming to our studios. I'm sure that our audience has been greatly benefited by the discussion of a topic which perhaps is very, very current and very close to everybody's heart. Thank you very much for coming to our studios.
Thank you very much for having me.
Thank you.
Thank you.